Hello, I'm Matt Ravenscroft from the UK. Today in this video, I'm going to show an update on the results of the BAR and show a case study. We do know there are lots of options for irreparable cuff tears. We have debridement, partial repair. We can cut the biceps, do tendon transfers, and of course there's the SCR. I'm also going to comment on the balloon, but the one I'm going to talk about today is the Bursal Acromial Reconstruction. Is SCR suitable for all patients? Well, we know it works well in the younger patient, no arthritis, a good cuff, a good functioning shoulder without any arthritis. But that's not every patient. So in the elderly patient with no arthritis, with a good compensated shoulder, we want to preserve the joint. And that's where we came up with the Bursal Acromial Reconstruction. So it's a graft, a human dermal allograft, which we fix to the undersurface of the acromion, and then the humeral head bears on this, which stops the pain. It acts as a cushion in between the humeral head and the acromion. But Gus Mazzacca's study actually showed it also helped to recenter the head, reduce some of the force on the deltoid, and to more normalize a defective cuff shoulder. So my results for the BAR, my first case was in December 17. We have 78 cases in the series with MRI scans at 3 months and 6 months, average male and female distribution, and average age, as we've mentioned, is the elder group, late 70s, early 80s. The biceps was absent in 2/3 of the patients, meaning their benefit they received wasn't just because we cut the biceps. And on MR scanning, all the grafts have healed. If you look at the visual analog score, these were painful shoulders, compensated shoulders, but painful, with the average visual analog score pre-op of about 8.5, going down to 1.5 at a year, and that was maintained. So it's not a no pain, but it's a pain that people are very happy and very able to deal with. And the same for the Oxford shoulder score. We started off with a good score. So these patients were compensated. They had good function, but just pain. So the increase in the Oxford shoulder score is because of their pain relief. On the scans that we can see at 3 months, you can see a fluid line between the graft and the undersurface of the acromion. At 6 months, that's gone. So the graft heals. And this is a pretty typical patient. He's 83 years old. He plays golf, and it's his left shoulder I did. These are his MR scans. And he has now no pain, good function, and he's back playing golf. We also noticed on the MRI scans in about a year that the graft forms a meniscus. Its form follows function, so it shapes and contours to the surface of the humeral head. Of course, we can't talk about results without talking about complications. I had one patient who felt something go, and it was one of my sutures or a knot that failed. I trimmed that back and she was fine. I've had one patient with acromial pain, and that settled down. I've had no infections. Early on in my series, I used to resect the clavicle and the acromion, but in 2 patients, I had an acromial stress fracture. Now I don't do that. I just resect the lateral clavicle, and I found I haven't had that complication anymore. So this is a case study I mentioned. She's an 82-year-old lady, a very keen marathon runner. She had a previous failed cuff repair. I did a balloon on her, and she had initial pain relief, but then the pain came back, and she wanted a more permanent fix. So I did a Bursal Acromial Reconstruction on her. At the time of doing the surgery, she was 9 months post-balloon, and I could see, as on the video, a lot of plastic debris still in the synovium. I did the BAR on her, and she's done very well at 3 months, and at 6 months, and a year, and now 3 years, she's still doing very well, and importantly, she's still running. And this is her. It's a right shoulder. She has a good, full range of movement with no pain, and she's happy. So looking at my results and comparing my results of my BAR to my balloon. So I have more BARs, 78 versus 32 balloons. The Oxford shoulder score needs to be more than 6 to be significant. And it wasn't in the balloon, but it is in the BAR. Complication rates was only 5% in the BAR and a much smaller revision to reverse. So this is how it all fits in with my treatment algorithm of SCR in the younger patient, BAR in that more elderly patient who I want to try and preserve the joint. And if we're not going to preserve the joint, then we still have the option, obviously, of a reverse. Thank you very much for watching this video.